Thank you for joining us today. If you are not an ATA member, please consider joining at https://atalink.org/become a member. Welcome to this on-demand seminar, AMCs en route care response to the COVID-19 pandemic. We hope you enjoy this presentation. The views expressed in this presentation are those of the speaker and do not reflect the official policy or position of the United States Air Force, the Department of Defense, the United States government, or the Airlift Tanker Association.
Good day. I'm Colonel Leslie Wood from Headquarters AMC, and this is Colonel Russ Franz, and we're here today to talk about Air Mobility Command's response to COVID-19 with regards to patient movement. Thank you for the opportunity from the Airlift Tanker Association to present on this important collaborative effort, and frankly, the single most intense collaborative effort across directorates and disciplines to support AMC's response to COVID-19. It was a privilege to be part of it, and we'll be presenting today. Next slide. Our views and perspective on this all of AMC effort. It's not inclusive of every effort with regard to COVID-19, but those associated with shifting our patient movement paradigm to meet the challenges imposed by this novel coronavirus pandemic. Next slide. In overview, we're going to talk briefly about patient movement strategy, the problem imposed by trying to adapt to the needs of patient movement in this environment, the AMC response timeline, an important aircraft airflow study, biocontainment transport capability, the first biocontainment transport mission that AMC conducted in support of this effort, and then what the future holds in an all-hazards approach going forward, and then we'll wrap it up. With regard to high-consequence infectious disease and patient movement strategy, we need to understand a couple of things. One, high-consequence infectious disease implies a novel or highly contagious infectious disease for which adequate treatments and infection control strategies are not well outlined or feasible. How this impacts patient transport in DoD is that we risk moving patients from an area with high disease burden to an area of low disease burden. This can transmit or make the pandemic worse, do the opposite of flattening the curve, and imposes risk to our aeromedical evacuation personnel and airlift personnel, because aeromedical evacuation operations is intrinsically tied to our airlift capacity using the same aircraft of opportunity. Additionally, that is why our current policy, Transcom instruction, is to treat in place to minimize the risk to both airlift capacity and increasing disease burden. Additionally, understanding that outbreak and pandemic response require a little different approaches. For an outbreak, like Ebola, for instance, a viral hemorrhagic fever, we have true high-consequence infectious disease beds in the United States, of which there are very few, like a couple dozen. This would be low-volume, high-acuity transport of very few patients to these specialized facilities. However, in meeting the need for a pandemic, where hospitals around the country are shifting how they respond in order to meet the needs of this pandemic because it's already everywhere, you can't use just those limited high-consequence infectious disease beds. Therefore, you need high volume as well as high acuity response from a medical perspective. Next slide.
So as we move forward with in response to our pandemic response, we quickly realized that some of the problems the teams were facing were, one, how do we assure host nation confidence that we could prevent the spread of infection from one region to another as we set up and execute a global biocontainment patient transport posture? Second problem, prior to COVID-19, the transport isolation system had never executed on an operational mission. Third problem, joint distribution process analysis centers projections for COVID-19 patient movement out of CENTCOM alone were anticipated to quickly outstrip our existing biocontainment transport capability. And 4, how do we create more capability either by moving patients without biocontainment while still protecting the flight deck, medical crew, and ground support personnel, or producing a capability to meet those requirements?
So, to put the overall effort in perspective with regard to timeline, we go back to January. On the 5th of January, the World Health Organization reported on a mysterious respiratory disease spreading to Wuhan, China. Within days, interestingly enough, we had AMC medics and CSTAR's Omaha infectious disease personnel at a National Strategic Research Institute meeting that put together international partners in biocontainment transport. And really this started the efforts of what we termed later as the AMC fusion cell, involving SG, A3, and CSTAR's Omaha personnel, to really be the group of medics to critically look at this emerging problem and start looking at what we had with which to respond, which was little at the time. We had a transport capability that we had never operationally flown, the transport isolation system, that was designed for, again, that high consequence infectious disease movement for an outbreak, that low volume, onesies, twosies, index case patients to move to these specialized centers within the United States. We had nothing prepared for a high volume pandemic patient movement mission. So over the month of January, while we watched as the CDC started screening at certain airports on both the East Coast and the West Coast, and the first cases of COVID-19 were reported in Washington State, the medics worked on adapting our CONOPS for the transport isolation system and our training and protocols and procedures to COVID from basically an Ebola capacity. On the 28th of January, an AMC OPT stands up to meet the needs of this emerging threat. And within a couple weeks, report on some very significant limitations in our ability to meet this emerging threat. 1, airflow and mobility airframes. We know less than we need about it and are very concerned that we don't have HEPA filtration and we have high rates of recirculation as far as we know, and further study is needed. Next, our biocontainment transport capability at that time, the transport isolation system, has very limited throughput, and we're concerned that we won't meet the requirement in a pandemic situation. Next, a common site picture across the enterprise doesn't exist as of yet in order for both across MAGCOMs, COCOMs, ground support personnel, Airlift, and medics don't have standardized mechanisms to deal with this to ensure appropriate infection control across the continuum. As states are locking down and we start going into sort of mandatory quarantines, it's recognized that we need multiple lines of effort in order to meet the needs of this emerging pandemic. So multiple things start happening. 1, evaluation of another biocontainment transport capability, the PBCM, or Portable Biocontainment Care Module, used by the Department of State, begins evaluation. And a team is sent from AMC to Charleston to begin that user evaluation and work with the Safe to Fly folks, the weapons systems managers, in order to make that additional capability safe to fly in mobility airframes. Next, TIS, or transport isolation systems, are really our only biocontainment transport option at that point. And so a lot of these were in storage and in crates and the patient support pallets that had been used within them had been shipped off to the KC-46 program. These were pulled back, and as many TIS as were in the inventory began to be built down in Charleston. Additionally, AMC began work on a patient movement plan, collaborating work of both the medics and line in order to develop that common site picture across the enterprise. Next, airflow studies were commissioned by AMC in order to better understand our limitations in airflow. Could we really move COVID-19 patients with an airborne virus in our airframes without biocontainment? The 18 TIS force packages were deployed in support of COVID to Charleston to have just-in-time ad hoc training delivered by AMC personnel to prepare them for this mission. And then on the 28th of March, as we'll hear, a joint urgent operational need was released in order to be able to develop new biocontainment capability. And that continued over the next several months. To the point on April 10th, we did our first transport isolation system from Ramstein to CENTCOM and back. And by the 1st of July, we started deploying new biocontainment transport capability as a result of this JUON that you'll hear about in subsequent slides, and then a light version as well. So to report on the first of these lines of effort, the airflow studies, this was a collaborative effort. We already had serendipitously, because of this effort to have user evaluation and safe-to-fly testing of the PBCM, we had AFOTech and a number of both civilian and DoD partners on tap for this PBCM effort. And they rolled directly into these other efforts in order to understand the airflow. So airflow in mobility airframes, we had across the DoD enterprise, academia, partners from the University of Nebraska and Clarkson University. AFOTech brought to bear the Army C. folks from Aberdeen Proving Grounds and the National Strategic Research Institute to bear. And these studies were done by taking both DNA and fluorescent aerosol tagged particles, releasing them in different areas of the aircraft, and then collecting aerosol and surface samples to look and see where those particles went. And much to our dismay, the two airframes that we use most for aeromedical evacuation operations, the C-130 and the C-17, performed the worst. The C-130, we had particulate distribution throughout the aircraft. Not even the flight deck was spared this. And the C-17, there was a modicum of protection in the aircraft, but no safe place for either flight deck or medical personnel to be out of PPE or personal protective equipment, specifically respiratory protection anywhere in the aircraft. This produced a number of concerns regarding how we would conduct operations, because human performance in PPE doesn't let you go 8 to 12 hours without doing things like taking off your respiratory protection to hydrate or conduct other activities of daily living. So we were very concerned that we didn't have safe mechanisms in our usual aircraft to conduct aeromedical evacuation operations outside of biocontainment. Next slide. Toward that end, it was beyond the scope of those aerosol studies to really look at the human performance piece. And we collaborated with A9 and used all of the available medical literature to understand human performance in personal protective equipment. A Cochrane database review published in April gave us a really grim reminder that even trained medical personnel in medical facilities in PPE for very short periods of time have high rates of self-contamination when doffing their gear, for instance, contaminating your body or your face when removing either that gown or your respiratory protection. And we were able to model that and show, for instance, in this example, in a C-130, with a mission of 4 hours duration, using an N95 respirator for both front end and back end personnel, as well as other usual PPE, gloves, gown, and eye protection, that our medical personnel and our load masters and boom operators in the back had about a 32% risk of self-contaminating, being exposed, and subsequently infected. And our pilots and flight deck personnel had about a 23% risk of infection. This was unacceptable in terms of risk of open air, causing us to really look carefully at risk strategies we could do if we were forced to conduct open air operations, and really caused us to reflect on the need to increase our biocontainment transport capacity. Next slide.
The next piece of risk analysis was evaluating the pros and cons of available personal protective equipment and making sure that that equipment was available in sufficient quantities to execute the mission. AMC Surgeon's Office, the United States Transportation Command, and the Joint Surgeons Advocacy was able to successfully attain, and distribute adequate supplies of gowns, gloves, positive air purifying respirators, N95 respirators, and face shields, and created a distribution system to track and ship these critical items. It's important to note that as we responded to COVID-19, we were in stiff competition with PPE between civilian medical treatment facilities, federal medical treatment facilities, and military medical treatment facilities. The Joint Surgeons Office had to raise our priority list for PPE to an equivalent level as those treatment facilities in order to obtain the necessary supplies and execute the mission. Next slide, please.
So toward that end, as we looked at increasing our biocontainment transport capability, we needed to focus on a couple of items that differed from normal operations. Normal aeromedical evacuation operations involve an aeromedical evacuation team, or AE team, plus CCAT, or critical care air transport team, as indicated by patient acuity, sicker patients, ICU level. But for this specific effort, we needed two other critical components. One, infectious disease or infection prevention personnel. For this effort, not only did they bring the cognitive bandwidth to have the expertise on the pathogen and our response, but critically to be those safety observers for operations in PPE to decrease the risk of self-contamination. This would prove critical to both any open aircraft operations we conducted and to biocontainment transport operations. And then for biocontainment transport operations specifically, we needed an additional small team for the support. In the hospital, for instance, we assume all the engineering controls exist to create and maintain negative airflow that will have adequate filtration. We cannot assume any of those engineering controls in an aircraft in that austere operational environment. So the support personnel are there strictly to keep the unit going, to make sure we have adequate airflow and appropriate filtration, and that we're really keeping the contagious aerosols within the unit. Next, adapting a PPE posture appropriate to the pathogen. Thanks to the University of Nebraska and our civilian partners who are actively looking at, and the CDC, at how this virus is transmitted, we were able to identify early on that this was an airborne aerosolized threat and adjust our PPE posture appropriately. Next slide. So what did we go out the door with initially? We had what we'd originally had for Ebola, and that's the transport isolation system. Again, it was originally developed during the Liberia Ebola outbreak in 2014. It was a metal framework with a clear plastic liner, and we modified the procedures and the concept of operations for COVID-specific transport capability. The ID team, again, consisted of ID physicians, infection preventionists, or public health personnel. And we added, of course, the biocontainment transport support personnel. The capacity at that point was to be able to put 2 3-module TISs on a C-17 and they could handle, with those 2 TISs, between 4 to 14 patients, depending on acuity.
And while we had the capability to move 4 to 14 patients on a C-17, it still wasn't enough. And this led to the development of a joint urgent operational need, spearheaded by A58, to develop to increase our capacity for biocontainment movement within the United States Air Force. Next slide.
So, thinking through a layered approach to solve that JUON, the patient movement system goes from point of injury to definitive care. And as an overarching DoD enterprise, we needed to solve all the pieces of that. So it was looked at in 3 different ways. The intra-theater piece, from point of injury to air hub, and that would be largely rotary wing to C-130. And then the strategic airlift, the inter-theater, which would be largely a C-17 lift. And then it was also looked at through civilian partners and DARPA and the recent Transcom study that you may have read in the news, looking at retrofitting commercial aircraft. However, the AMC effort during this time specifically looked at strategic airlift initially with the negative pressure Connex, or retrofitting a 40-foot Connex box to become a biocontainment transport unit. And then subsequent to that, a C-130 version, the negative pressure Connex Light, that could be adapted for the C-130 and cover down on some of the intra-theater mission. Next slide. So the negative pressure Connex was the first effort. The team assembled in Charleston, as I mentioned, serendipitously. We had AFOTEC personnel. We had weapon systems managers, because we were all on site to both spool up TIS capability and to conduct that user evaluation for the PBCM. And that team turned around the next day and became part of the design team for the negative pressure Connex. This effort, spearheaded by the program office, went from drawing on a napkin, as it were, to a prototype available on site in Charleston in less than 2 weeks. And within 3 months, a fielded capability doing its first mission. And that has the capacity, the negative pressure CONOPS, to transport up to 24 ambulatory patients, low acuity, or up to 8 litter patients, complete with emergency litter equipment and 2 attendants in the box. It also has the capacity to shift configurations from all seated, again, low acuity ambulatory patients to high acuity litter patients, and go across the continuum of care to be able to have CCAT and ICU level capacity within it. It also solves the problem of being in PPE for prolonged periods, because it has an anteroom at the far end of the patient care area, for medical providers to be able to doff out of their PPE and leave the unit and be replaced by their teammates during missions. Shortly to follow after that was the negative pressure Connex Light, a 30-foot Connex box designed for a C-130. With similar capacity, or I should say similar capability, as a negative pressure Connex. It could handle up to 14 ambulatory patients and 3 litter patients, complete with all of the emergency equipment and such as the negative pressure Connex. And it was designed for the intra-theater mission. It did its first mission on August 16th. And now we'll talk about the first mission that we did in biocontainment in the transport isolation system.
So we're going to discuss Reach 725. This represents a historic achievement for Air Mobility Command. This was the first operational use of the transport isolation system to perform aeromedical evacuation on 3 U.S. contractors with a COVID-19 infection. This culminating in years of testing, prep, training across the joint force with multi-organizations in regards to Ebola response, and collaboration with AMC, A3, and SG, Joint Base Charleston as a testing site, and also with collaboration with Seastars Omaha to develop the procedures to be used for the transport isolation system. This was quickly adopted into an existing system to meet the needs of COVID-19 patient movement, On 8 April, a warning order was sent out by United States Transportation Command to the 618th Air Operations Center, whereby the original patient movement requests were received for 2 patients originating out of Afghanistan to be moved to Ramstein, specifically Launchpole Regional Medical Center. The crew was placed in crew rest, and the 86 medical group was asked to assist for N95 testing for the front end crew, and that was coordinated within 2 hours. Next slide. On 10 April 2020, the pre-mission brief was actually led by the Air Operations Center to ensure that there was clear communication between the Operations Center, the front end crew, the back end crew, and the receiving facilities around the globe. Again, we had never executed this mission, and safety was paramount. At 1:30 a pre-flight preparation on the aircraft was complete. Additional information on patients were received. We did the operational checks were done on the transport isolation system, and at 03:03 the aircraft departs. Next slide, please. Approximately 9:30 the aircraft lands in Kabul. The medical crew director contacted the TPMRC due to validate an additional patient that was added to the mission en route. They understood that there was supposed to be a 4th possible patient from Bagram, but that patient was not validated. And at 13:09 the aircraft departs carrying 3 patients, with 1 medic remaining inside the transport isolation system at all times. Next slide, please. At 20:49 the aircraft arrives in Ramstein Air Base. The local medical group receives the patients on time. The critical care transport team traveled with the patients to Launchpole Regional Medical Center. Transport isolation system disinfection procedures started, and crew members departed the aircraft. Again, at 2300 the Air Operations Center led a mission debrief with the crew and Air Mobility Command via a TCON to analyze lessons learned from that mission. Next slide, please. And here are some of the lessons learned from the mission. We quickly needed to recognize that we need to adapt at the speed of relevance, requires team agility, whereby the AMC COVID-19 patient movement plan was published mere hours before the first biocontainment transport mission actually executed. The front-end aircrew obtained N95 fit testing just in time. What we needed to do is develop new communication strategies were needed to overcome the challenges of working inside a metal box and communicate between the personnel in the box and out of the box.
Understanding that biocontainment transport missions are logistically complex operations. Success moving forward with ample hardware to conduct the mission will be about how we prepare our airmen and standardize our processes across the patient movement continuum. In addition to a patient movement plan to have that common site picture, we need UTC and formal training course development. The impressive ad hoc just-in-time effort by AMC personnel to prepare our airmen, excellent effort in the context of a pandemic. But going forward towards an all-hazard approach, really need that formal course, training course development and UTC. That is in process at present. Additionally, doctrine, specifically the AMC COVID-19 patient movement plan, will need to adapt toward an all-hazard approach moving on from COVID. Next slide. Toward that end, contagious patient movement was really an unknown across the enterprise prior to COVID-19. A shared understanding was needed across all the MAGCOMs and COCOMs to support this emerging global mission. And risk mitigation best practices are defined for both open air, if that's what you're left with, versus VISA biocontainment transport. And this document is becoming a living document as we obtain more information about COVID-19. But going forward, this document will have to reflect a broadened approach toward all hazards approach. We need to think beyond airborne novel coronavirus to viral hemorrhagic fevers, Marburg virus, or bioweapons such as weaponized anthrax. Do we have what it takes at this point with this amazing capacity and capability that's been developed over the past 7 months with the COVID-19 pandemic? Do we have what it takes to meet the needs of those threats? Toward that end, We have strategy, policy, and doctrine as outlined, but we need to recognize also the high consequence infectious disease infrastructure limitations. We have very few beds in the United States that could handle that high level containment required. But we also need to think about our biocontainment transport capacity. The NPC and the NPC Lite are designed but need validation for all hazards. They are validated for the airborne threat that exists with COVID, but we need to make sure that our doctrine reflects the procedures, policies, and PPE posture we're going to need in order to keep our folks safe and reduce the risk of exposure. And that will change depending on pathogen. We'll need different procedures for viral hemorrhagic fever viruses than we'll need for other threats, such as weaponized anthrax. Formal UTC development and training are going to really be critical to those efforts to develop an all-hazard approach and capability. Additionally, we must also recognize that we still have a gap in the patient movement continuum, and that is in the single patient isolation unit. Next slide. In addition to having a biocontainment transport unit that'll fit in a C-17, we also need to think about our austere environments where distance is tyranny and we don't have C-130s or other aircraft appropriate to those locations, where we may be dealing with point of injury and rotary wing or non-standard contract aircraft. Single patient isolation units will be another gap that we need to fill going forward to meet an all hazards approach to contagious patient movement. Next slide. In conclusion, we'll have an enduring need for all hazards transport capability. And we must understand that the DoD aircraft airflow limitations that we confirmed during the intense study done earlier in this year imply significant risk in execution of open air movement with highly contagious disease.
And as we've mentioned several times, one of the conclusions to executing this mission was that the AMC COVID-19 response represents an intense collaboration across multiple disciplines and directorates with tremendous success. Starting in January 2020, AMC had a biocontainment transport capacity that had never been flown on an actual mission. And now here in October 2020, we have safely moved roughly 400 patients with more biocontainment transport capacity than any other single entity on the planet.
And success moving forward with this ample hardware and this amazing capability that's been developed. In order to conduct this logistically complex biocontainment transport mission, we will need to invest in preparing our airmen, in training and sustaining in order to be ready for an all hazards approach. Thank you for this opportunity to present on this vital AMC effort in response to the COVID-19 pandemic.
The views expressed in this presentation are those of the speaker and do not reflect the official policy or position of the United States Air Force, the Department of Defense, the United States government, or the Airlift Tanker Association. If you are not an ATA member, please consider joining at https://atalink.org/become-a-member. Thank you for participating in our virtual presentation. Please close this window and return to the agenda on our website to view another presentation.